Today I'll be presenting a very straightforward case. The point of interest is just show one of the very interesting potential, how to differentiate it from the normal bundle potential. So basically a 40-year-old gentleman presenting with recurrent episodes of SVT despite on being drug therapy. This is the baseline ECG. So showing a short PR with pre-excitation, with negative delta waves in 2-3 AVF, and there is a positive delta wave. I will say this is a submaximal pre-excitation. So we can just say this is a posteroceptal or left-sided posterior or a posteroceptal pathway. So, and this is the Tachy ECG. This is the baseline ECG in the lab. So here now we are pretty much convinced that this is a left-sided posterior, either posterior or a posteroceptal pathway. So here is the baseline ECG. Again, this is a submaximal pre-excitation. The HV is not that short or that negative. Okay, this is on atrial pacing. There is the excitation. This pre-excitation is becoming maximal, and the HV is also getting shorter. This is the Tachy induction, and we can say this is the earliest activation is somewhere in the C5-6 region with bracketing. Evidence of bracketing is there. So this is the tachycardia cycle length was 330 milliseconds, and we did some maneuvers, though it may not be essential, but this is the VOP showing PPI minus TCA, tachycardia cycle length around 60 milliseconds, and obviously it is a VAV response. This is somehow, though it is a left-sided pathway, just my ablation catheter this is the signals in the middle cardiac vein, and I have ruled out coronary sinus diverticulum by doing an angiogram, and in the middle cardiac vein we have a good, we can see the good signals. And I think the accessory AP potential is also seen, but I have not given ablation there because I thought that I will go on the left side. So this is the one slide where I am very interested. This is the one slide I want to stress on. So this is while I am mapping on the left-sided posteroceptal region, so what this potential could be. What is the differential diagnosis of this potential could be? So this could be either of the two. This could be either a left-sided bundle branch potential or an accessory pathway potential. So actually, and this is the another. This morphology is different. Actually, you can see. You'll see. And on this morphology is different. No, you can see this previous slide. We have got AV and in between this thing, and here. On atrial pacing, we can see this HS moved near the V, and the distance between this so-called this potential is 33 milliseconds. See, this is mapping in the sinus rhythm. This is only A and V fused together, good signals. This slide, when the catheter was here, not this catheter placement is wrong. When the catheter is just here above this coronary sinus in this region, I got a signal like this, but when I did to differentiate whether it is an accessory pathway potential or a left bundle branch potential, I did atrial pacing, and that atrial pacing moved this potential away from the atrium. That is when the pre-excitation is becoming maximum, this potential is also moved. So I avoided ablating in this area. And when the catheter tip is here. This is the AV signal, and this is the unablated, and I did atrial pacing where I showed the difference or the gap between this and his is around 33 milliseconds. So it was very close. It's just above here, the signal was this, and just below here. So what I am concluding is that this is the left bundle branch potential, or this is the left bundle branch potential. So if I would have ablated just somewhere here, I might have landed in complete out block. This is the atrial pacing maneuver, sir. So during atrial pacing, what happens is his moves towards the, during it becomes maximal excitation, so his is moving towards the V. But this potential is not moving with this. If it is a his, it would have moved. So the distance would have become the gap. The gap should have become less. If it is the accessory pathway potential, then it will stay away from the his. Or we can give atrial extra stimulus also to differentiate. So atrial extra stimulus also will separate.